We're back with our series, Real Men Wear Gowns, to get men to put on that gown, get that scan or test, and be proactive when it comes to our health. And for Heart Health Month, we are taking your questions straight to the expert. Dr. Anthony Bashall is a cardiologist with Franciscan Health and is here to help us out. Thank you so much for being here.
Great, thank you.
You ready to get started?
Absolutely.
Okay, so we asked on social media, what do you want to know when it comes to heart health? Got a ton of questions here. Start with number one from Michelle. Is the heart scan advertised for $49 helpful or hype?
Well, I think it's underhyped. I think it's one of the best $50 you'll ever spend towards your health. And firstly, it really helps if you understand what the test is. To call it a calcium score, most people think of a calcium score as something we take in our diet for our bones, but it's not. What the body does is it builds cholesterol blockage. The lining of the blood vessel gets damaged. The body then fills that with cholesterol and then puts bits of calcium on top of that cholesterol. And that scan can see the calcium. But wherever calcium is, you have cholesterol blockage, which indeed is coronary artery disease. And you get a variety of scores, but it shouldn't be there. So people ask, well, how old do you have to be? Well, about 15 years ago, we said age limits. Now it's really opened up, so between you and the provider, you can decide and negotiate what it perhaps should be. But one of the things that's perhaps a newer thought is, if you're younger, under 40 for men and under 55 for women, and you have an abnormal calcium score, even if it's very low, it shouldn't be there. And you may have more of the cholesterol blockage the scan can't see. But you and your doc can get together and work out treatment programs and treatment plans for this. Good cholesterol control, good blood pressure control. If you smoke, really pursue efforts to cease smoking, and diet and exercise will help. But it is one of the best ways to know. And a lot of times you'll go to your doc and they work out your risk. Well, this just adds to that, but it actually is a direct look at your heart, at the blood vessels. And also to bear in mind, if you have blockage in your heart, you may have blockage elsewhere. So it can lead to health risk reduction of future heart events, heart attack, and stroke.
Okay, for just $50.
For $50.
That seems like a heck of a deal.
Yeah.
All right, Julie says, I want to know more about AFib. It almost killed my dad. Except for some extremely exceptional circumstances, he's still here today. I don't really understand this disease. Is it hereditary or environmental or both?
It is both. It is predominantly an environmental, but coming from a family where it was hereditary, where a young member of our family at 22 had atrial fibrillation with incredibly fast heart rates. And she picked up on a watch. And she went to her doc, and we thought it was one kind of rhythm. And she actually called me one day and said, oh, it's happening again, Uncle Tony. And I said, well, how fast are you going? She said, about 180. I said, well, what does the doc in the ER say? She goes, I'm at home. I go, what are you doing at home?
Yeah,
and she was dizzy and lightheaded. They got to the ER, they did an EKG, and she was diagnosed with atrial fibrillation. Very unusual, very rare, but it does exist. A few months after that, they ablated the AFib, which is a procedure done by a certain type of cardiologist called EP, and the AFib was made to go away, and she's been fine ever since. That is rare. What is incredibly common, and probably more likely in your dad, is the AFib that comes with people gaining excess weight, having sleep apnea, and you have an irregular rhythm where the heart loses control of the electrical activity. And it kind of splits it into two evaluations you need to do. So perhaps you notice on your watch some irregularity. You go to your primary care physician, they get an EKG, put a monitor on, and they find you have AFib. And it's very common for people not to be aware of symptoms beyond perhaps some fatigue or some exertional shortness of breath.
Which can be explained for a lot of things.
Exactly. So a lot of people with AFib are a little bit older, they're carrying excess weight, and they go, well, I've gained weight, I'm getting older, that's why I'm short of breath. But AFib is highly associated with sleep apnea, obesity, and heart failure. So when you find it, the most scary thing with AFib, number one, is risk of stroke. The irregularity of the heart rhythm leads to blood clots forming inside the heart, which can break off and cause a stroke, a devastating event. So we very quickly put people on blood thinners. Now, people often say to me, oh, doc, have I got to be on blood thinner for life? No. We have a new procedure, again, the electrophysiologists of cardiology can put a device in your heart called a Watchman, which seals off the area where the clots form, and you can come off blood thinner. And this is becoming a very acceptable procedure. A lot of patients like it because they can come off blood thinner. Bear in mind, when we put you on blood thinner, you're on it for life.
Okay.
The second component to AFib is I don't feel good. I just don't feel good. And it's a little bit of a pack hunter because it's associated with obesity, with sleep apnea, and many other medical problems like diabetes and hypertension. So in order to treat it, you need to treat everything. But one thing you can do is there's medicines to keep the heart rate under control. You can have it ablated and make it generally go away so you feel much better. But you also want to address the sleep apnea, get a sleep study. The newer medications, the GLP-1s, they have an anti-inflammatory component, and they've been shown to improve the outcomes of people with AFib. They've been shown to improve the outcomes and sometimes reverse sleep apnea, which contributes to AFib, and they help people lose weight, which also helps reduce the burden of AFib. So it's almost like it's what's not to like. So if you have AFib, risk of stroke we can address with blood thinners and a procedure called a Watchman. We can ablate it, and then we have numerous others where you want your physician to pay attention to more than just the AFib, particularly like sleep apnea sleep studies. The final one that's really concerning with AFib is, let's say you have AFib and you're feeling okay and you've got a reasonable rate control and you're on your blood thinner, but it comes in the season, you get the flu, you get pneumonia, it irritates the heart, and suddenly the AFib starts to race. Well, now you've got multiple layers of problems. You've got flu suppressing your immune system. You've got pneumonia making it hard to breathe. And now when you go AFib and it races, you can congest into your lung and you get heart failure on top. And these people are particularly sick, and it can be quite a challenge to turn that around in the hospital. But it's this kind of process with flu and viruses and COPDs that tend to fill our hospitals this time of year. But by getting ablations and treating all these other factors ahead of time, we can help prevent it, and potentially getting vaccines if you choose to do so.
And it starts with listening to your body and knowing your family history.
Yes.
Okay.
And perhaps one thing to add is, it's amazing how many people come in, and we found out they've been in AFib for quite a while, not really aware of the symptoms, but when we ablate them, they go, "Doc, I feel so much better." But occasionally, they don't.
Wow.
Most of the time, they do.
All right, next question from Tommy. Tommy says, I had 3 stents put into my heart after a widowmaker heart attack. All arteries were blocked. Do stents go bad, and how long do they last?
This is a great question. So the categorical answer to that is rarely they do. Rarely they do. But it fits into 2 categories. The first category is when the stent's first put in. Within the first few weeks, they may form a little blood clot inside, and you'll get a repeat of the symptoms that perhaps took you to the hospital, whether it's chest pain, jaw pain, intense fatigue, arm pain. Intense fatigue and shortness of breath are really emerging as a heart attack symptom. And that can be a sign in the short term you're clotting it off. But if you're a few years out from the stents being put in, and sometimes the cholesterol starts to reaccumulate inside them, and sometimes we stress test and check and we find abnormalities, or we send you back to the cath lab and have to open them up. But there's a couple of things you can really do. In the first place, you want to make sure you're given at the time of a heart attack or stent placement, you'll be given aspirin and maybe a drug called Plavix or Prasugrel or Brilinta. It's really important to listen to what your interventional cardiologist says about taking those. We used to have people take them for years. You don't have to do that usually now. It can be a matter of months or to a year, but it's highly variable, but you stay on that, and that helps prevent that clot form. So to have that happen is an incredibly rare event, less than 1%. And the longer term version of it happening, that's often in people who struggle to give up smoking, who perhaps their blood pressure is a little bit high, the cholesterol perhaps is at 70, their blood pressure is a little bit high at 130, 140, and it hasn't been enough to bring down the cholesterol, blood pressure. And one thing that's a new emerging marker of heart disease we really have to pay close attention is inflammation. And it's easy to check with a blood test called a high sensitivity CRP. And if we get our cholesterol under control, and we actually have some medicine that can directly bring it down. But to put that in context, it's not a commonly tested thing. When we're looking at our female patients, high levels of inflammation are one of the highest risk factors, even more than cholesterol, for future heart events. And the treatment of it, get your cholesterol down. You want your bad cholesterol below 55, particularly if you have blockage. You want your blood pressure between 120 and 30 with no lows.
Okay.
A low is harmful, so sometimes we have to run people a little high. You want your markers of inflammation down. And then, once again, we're looking at this category of meds called the GLP-1s they've clearly been shown in people who have heart attack to reduce the risk of a recurrent heart attack before they lose weight. As we talked last time, weight loss is a happy side effect. Yeah. It's the reduction of inflammation we think, but clearly shown to benefit. And this requires a really comprehensive, complete approach to care. If you want to look after this and keep those stents open, you have to look after everything. And then smoking, and I have to get this out as a former smoker, I wish someone had told me this, is the withdrawal is awful. I experienced it personally. The cost of smoking financially is very, very damaging now, and I have patients who quit smoking and buy cars, but the withdrawal lasts 3 to 4 minutes. You have to tough it out for that, and then you're okay. Then it comes back, 3 to 4 minutes. And I wish someone had told me that, because when I would hit my moments of withdrawal, I'd be like, okay, I'm done. I'm going to get some cigarettes.
Let's stay strong. Just
stay strong. A few minutes, yeah. And think about this. I was joking with a patient, and she had quit smoking. I said, oh, where are you going? Hawaii? She goes, no, the Caribbean.
Oh, man. That's a great incentive, right?
Yes.
Yes, absolutely. Finally, curious about what diet to follow for heart health. Keto, carnivore, Mediterranean, it's so hard to sort through trending and truth. Man, is that true? It
so is. But I've got some very clear answers. As a cardiologist, I do like to focus on dietary advice, but I don't have too much time with all the other aspects of care we talked about. So number one advice, if you have a diet that works for you, that's keeping your weight down and keeping you healthy or has helped you lose weight, that's probably the right diet for you, number one. Number two, the Mediterranean is probably the best studied, has good heart health data. I would advise not eating as much carbohydrate as it suggests, but the Mediterranean can't go wrong there. Number three, this is going to be a little uncontroversial right now, a near vegetarian diet with plant-based proteins has clearly been shown to be the most overall healthy diet. Number four, because I run out of time with my patients now, I'll just say this, avoid processed food. Very difficult. Our brains love processed food, our bodies do not. 100 calories of processed food, you will gain more weight than 100 calories of non-processed food. So I suggest to patients, if you're eating a fish, make sure it looks like a fish.
Okay.
Okay. If it looks like a plant, and avoidance of eating out. It is very common. I was at a conference not long ago, and they showed 2 salads. One was 1,200 calories, and one was 300 calories. One had been made in the restaurant, one had been made at home. So it is a challenge. Food prices are high, but avoiding processed food, which is difficult because people like it. But that's kind of the advice I give. The diet works for you. Mediterranean, cut the carbs. Vegetarian, avoid processed food. Eat out as a treat.
All right, Dr. Bashall, as always, thank you so much for your help. Look forward to doing this again sometime.
My pleasure. Thank you for having me.
Absolutely. Okay.